So good evening everyone, this is Dr. Vineet Sehgal and welcome to this rapid revision series, and today we will talk about some image and the video based questions in ophthalmology. So as you can all remember that I am there on the Unacademy Learning app, and you can have the best of the NEET PG platform with the Plus subscription. In the Plus subscription you would get daily live classes, live tests and quizzes, structured courses and unlimited access to all the video lectures. You can also go for the iconic subscription where you would get the best of the Unacademy with the best of the prep letter. You would have live classes and batch courses, you would be having video lectures, question bank 2.0, live test and quizzes and the rapid revision course. There is another offer for you. If you want to go for a 3-year subscription, you can get it at never before price, that is just 58,500, and as you go down for the 24 months, 18 months and 12 months, you can also get it at the discounted prices. Also remember, there is a 3+1 program where you would get after a 3-month subscription you would get 1 month free, and there is a limited time offer for you. By 3-month subscription, get 1 month free of cost for all of you. Lots of batches which are going on, and also remember, lots of MCQs are there on the Unacademy Learning app where you can basically continue and practice them for your NEET PG preparation. Okay, so you can just download the Unacademy Learning app and go for a Plus or the iconic subscription with all of us. So today I will be just talking you about some important image based questions. Okay, so first of all, this picture, if you can appreciate. So these are the Keratic Precipitates. Okay, these are called Keratic Precipitates. If you can see here, these are basically the pigments on the endothelium of the cornea. Okay, and in which condition you get Keratic Precipitates? Anyone? So Keratic Precipitates, they are basically signs of uveitis. Now remember, these Keratic Precipitates, they can be fine Keratic Precipitates, and remember, the fine Keratic Precipitates are seen in the non-granulomatous uveitis, and you may be having a larger big Keratic Precipitates that are called mutton fat Keratic Precipitates. Okay, mutton fat Keratic Precipitates, and remember, mutton fat Keratic Precipitates, you get it in granulomatous uveitis. Granulomatous uveitis, like anyone? So the examples of granulomatous uveitis are diseases like tuberculosis and sarcoidosis, where you can get the mutton fat Keratic Precipitates. Now remember, Keratic Precipitates are not the signs of active uveitis. They can be seen in the active uveitis as well as they can see it. You can see it in the healed uveitis as well. Okay, chalo. Then we have another feature which can be seen in the uveitis, which is called festooned pupil. Now what is the meaning of festooned pupil? If you can see in this picture, you have the irregular shape of pupil and you have the iris and the lens addition at some points. So you are getting a irregular pupil. And why there is a irregular pupil? Because of the formation or the addition of the iris at various points towards the lens. So whenever you dilate the pupil, it would be a poorly dilating pupil, and it would dilate at some point and would basically not dilate at other points. This is called festooned pupil, and festooned pupil is also a characteristic of uveitis. And what are these called? These are called posterior synechias. Chalo, let's move to our third picture. Third picture, this is basically a patient of UVL melanoma. Okay, if you can see, there is a tissue, uveal tissue, which is protruding from the scleral area. And remember, the UVL melanoma is the most common primary intraocular tumor of adults. Okay, if they ask about the most common primary intraocular tumor of children, okay, if the question changes and they ask about the most common primary intraocular tumor of children, then your answer is different. What would be the answer? Can you tell me in the comment section? Then the answer would be retinoblastoma. Okay, so both of them are different here. Chalo, let's move to our next picture. This is a OCT picture, and OCT picture is basically showing you a central serous retinopathy. Now you have to appreciate these 9 layers. These 9 layers of the retina, they are called neurosensory retina. Okay, And then we have this 10th layer, the hyperreflectile layer, which you can see. This is the retinal pigment epithelium. At the center of macula, what you are seeing is this space. This space is called, anyone? This space is called subretinal space. Okay, there is an accumulation of the serous fluid in the subretinal space. This is basically called a central serous retinopathy. Okay, the most important thing in the central serous retinopathy is that the fluid collection is beneath the 9 layers. So 9 layers के नीचे और 10th layer के ऊपर जो subretinal space है, this here there is the fluid collection. This is called central serous retinopathy. Okay. Now we can have another picture where you are having a macular edema. Okay. So in this picture, if you can appreciate, there are cystic spaces in the inner layers of retina. This is called macular edema. Also, if you can appreciate that the retinal pigment epithelium is deranged. Okay. So the retinal pigment epithelium is deranged, is destroyed, and the leakage of the capillaries are basically causing the edema here. So this patient is having a choroidal neovascular membrane, okay, which is basically a wet ARMD, and with the wet ARMD you are also having the macular edema in this cases. Okay, chalo. The next question is pigment epithelial detachment. Okay, if you can see in this picture, there is a PD here. Okay, so this is the retinal pigment epithelium. This is the retinal pigment epithelium, and you can see the retinal pigment epithelium is detached at this level. Okay, so retinal pigment epithelium is detached from choroid this level. This is called a RPE detachment. Okay, chalo. Then the next spotter is of epiretinal membrane. Okay, so now see how the normal OCT looks like. So you have a dip at the level of the center of macula. Here, if you can see in this picture, there is a membrane which is over the internal limiting membrane. Can you appreciate here, Steffi? So there is a membrane over the internal limiting membrane. Okay, this is called epiretinal membrane. Okay, and what this epiretinal membrane has done is it has basically caused a loss of the foveal contour as well. This is the normal shape. Okay, and here you can see the foveal dip basically is not there. There is an elevation at the level of the center of the fovea. Okay, so this is called basically a epiretinal membrane. Is it clear? Okay, chalo. Then we have the next spotter here. This is basically a cystoid macular edema. If you can see here, the cystic spaces are all there in the inner layers of retina. Very typical of the cystoid macular edema. Sometimes they ask you a question, in which drugs, what are the drugs which can cause cystoid macular edema? Can anyone tell me? You can just remember it with a very simple mnemonic, that is the NEET PG. Okay, N goes with the nicotinic acid, EE goes with the epinephrine, T goes with the tamoxifen, PG goes with the PG analogs. Okay, so NEET PG are the drugs which can cause the cystoid macular edema. Okay, then we have this picture where you are seeing there is a something new vessels which are basically being seen beneath the RPE. Okay, so RPE के नीचे आपकी जो vessels दिखाई दे रही हैं, these are basically the choroidal neovascular membrane, or they are also called wet ARMD. Okay, chalo, let's move to the next spotter. This is our next spotter where you can see that the central layers are absent here. Okay, so the layers which are there in the center of the macula, they are absent. So this patient is basically suffering from a macular hole. Okay, do not basically think this is a macular edema. So yes, there are some cystic spaces here, but I cannot classify it as a macular edema, because the definition of macular edema is when you are having the increased thickness of the retina. Okay, here you cannot appreciate increased thickness. Yes, there are cystic spaces, but this is a feature of a macular hole. Okay, so then there is a picture where you can see the wet ARMD fundus photo as well as the OCT here. You can see the RPE is basically elevating. but this can also be there in a dry RMD. So when you see the fundus photo, you can see a hyperpigmented scar also here. Okay, so the hemorrhage and the scar here basically are telling you that this patient is not a patient of the dry RMD, but this is of wet RMD. Okay, then this is a picture where you can see the ultrasound B scan. Okay, why this is a ultrasound B scan? If you can see, this is the vitreous. Okay, this is your vitreous cavity, and you can see lot of membranes in the vitreous. Here you can see very thick membrane which is attached to the optic nerve head. So this is basically a retinal detachment. And ultrasound B scan is a very important modality whenever you do not have the access to the view of the retina and the vitreous, and there may be a corneal opacity or a very hypermature senile cataract or an uncooperative patient like a very small child where you cannot see the retina. Okay, so then this is a picture where you can see the USGB scan which is there in the endophthalmitis. Now, how can you say that this is a endophthalmitis? You can see some vitreous haze here. Okay, so this vitreous haze, if you can appreciate, the spikes with this vitreous haze are less as compared to the spikes that are coming after the sclera, which is basically being there. And when the acoustic rays basically hit the sclera, they basically cause the large spikes, but when they hit the smaller opacities, they basically make the smaller spikes. Okay, so this is a USGB scan which is showing you the endophthalmitis, or there may be hemorrhage, vitreous hemorrhage in these patients. Okay, chalo. Then we have a USGB scan which is showing a retinoblastoma or intraocular mass lesion. If you can see a very dense mass, okay, the thickness and the density of this mass is basically correlating with the scleral thickness as well. So this patient may be having a retinoblastoma, or it may be having an intraocular mass lesion, like in the adults you can have a UVL melanoma. Okay, then this is a picture of a primary optic atrophy. Why it is a primary optic atrophy? If you can appreciate in this picture, you can definitely see that there is a pale optic nerve head. Okay, there is a pale optic nerve head, but the vessels you can see are absolutely normal. So some conditions like macroadenoma of the pituitary, or some cases like multiple sclerosis, they may lead to a primary optic atrophy. Very important in a primary optic atrophy, the vessels are normal and the disc margins are distinct there. Then we have a Neuro Retinitis. In this picture, if you can appreciate, there is a disc edema. Very important. You are having a disc edema. You cannot see the margins of the disc, and also if you can appreciate, there are exudates all around the disc margins as well. Okay, so these exudates around the disc margin, they are basically telling that there is an inflammation of the retinal nerve fiber layer. So this is a patient of Neuro Retinitis. Okay, then this is a secondary optic atrophy. Now what is the difference between the primary and the secondary optic atrophy? Here you can see a chalky white disc, and around the disc you can see some atrophy, plus also see the vessels here. So vessels are attenuated and having sheathing as well. So the conditions like vasculitis, retinitis pigmentosa, in these cases you can have a secondary optic atrophy. Okay, so remember, secondary optic atrophy is post retinitis pigmentosa or post vasculitis or any post intraocular disease which can cause a chalky white deposit, and you have the arteriolar attenuation as well as the signs in the blood vessels. They are called the secondary optic atrophy. Okay, then we have this picture of the optic neuritis. Now see this picture, this is a optic neuritis, and see this picture, this is a optic atrophy. How would we differentiate between the optic neuritis and optic atrophy? In the optic neuritis, you can see there is a margin, the margins of the disc, they are blurred, and in the optic atrophy you can see the definite margins. So the optic neuritis can basically lead to the next stage, which is the optic atrophy. Okay, and what is, sometimes they ask, what is the most common cause of optic neuritis? The most common cause of optic neuritis is multiple sclerosis. Okay, so it is multiple sclerosis which is the most common cause of optic neuritis. Then this picture is a Papillaedema. Here you can see the blurring of the disc margins, there are hemorrhages also. Then why it is not a optic neuritis and why it is a Papillaedema? The reason here is that the patient is having a Papillaedema because you can see the dilation and tortuosity of the blood vessel as well. So very important is in a papillaedema you see dilation and tortuosity of the blood vessels as well, which you usually do not get in a patient of optic neuritis. See, the vessels are normal here and here the vessels are dilated. Are you getting my point? Okay, chalo, let's have few MCQs for you. A patient presented with the following clinical picture and difficulty in vision when he drives in the night and some strong headlight comes in front of him. Identify the type of cataract. So you can see the slit lamp. In the slit lamp, you can see the opacity in the posterior part of the lens as well. So what is this type of cataract? Shield cataract, cortical cataract, blue dot cataract, or posterior subcapsular cataract? So very good. If you can see here, the opacity is just beneath the posterior capsule, and when there is a constriction of the pupil, then the light ray would basically go and hit this opacity. So this is a posterior subcapsular cataract. The more would be difficulty in the patients who are having the posterior subcapsular cataract and they drive in the night and some headlight comes in front of them, and also they would have more difficulty in the bright sunlight. Okay, chalo. Then we have this type of cataract. Identify the type of cataract. You can see wrinkling of the capsule as well as very hard cataract, and you cannot see the vitreous or the inside of the retina. What is this type of cataract called? So remember, in a nuclear cataract, you can definitely see the capsule and the cortex, and you see the opacity in the center of the nucleus. In the blue dot cataract, you would only see some punctate opacities here and there. In the hypermature cataract, you would not be able to see anything in the cortex or in the nucleus. You have a very dense cataract, and also you are having the wrinkling of the anterior capsule. Okay, so this is a hypermature cataract. Okay, so next question is identify the procedure which is going on. Your options are applanation tonometry, gonioscopy, indirect ophthalmoscopy, or direct ophthalmoscopy. So if you can see, I am basically touching the instrument and putting the instrument over the cornea, and see, I have not put the blue light here. I have basically holded the instrument and I am seeing through the yellow light here. Okay, so this is basically a patient where I am going to do. Very good. This is a gonioscopy. And why we do a gonioscopy? Basically, if we have to discuss and we have to differentiate a angle closure glaucoma from the open angle glaucoma. Okay. Chalo. The next question is the investigation is useful for all of the following except. Your options are retinal detachment, lattice degeneration, retinopathy of prematurity, or optic neuritis. Try to answer. So this patient, if you can appreciate in this picture, I am doing a indirect ophthalmoscopy. The indirect ophthalmoscopy is done whenever we have a patient and we have to see the periphery of the retina. Okay, so periphery of the retina is basically seen in the retinal detachment, lattice degeneration, retinopathy of prematurity. For the optic neuritis, we do not need an indirect ophthalmoscopy. We can do it with the direct ophthalmoscopy or with the slit lamp examination with a 90D. Okay. So next question is not true regarding the procedure being done. Uses piezoelectric probe. The IOL is usually put in the bag. May lead to posterior capsule rupture. Need 5 mm corneal incision. So first of all, what is this surgery going on? So if you can appreciate, we have put a probe inside the lens and we are basically cutting the lens and chopping the lens. This probe then basically can aspirate all the lenticular material as well. So this is a phacoemulsification which is going on. Okay, so this is a phacoemulsification which is going on and it uses a piezoelectric probe. The IOL is usually put in the bag. What is the meaning of bag? So between the anterior and the posterior capsule, I put the intraocular lens. This means the IOL is put in the bag. Now whenever we are putting this instrument can basically lead to the posterior capsule rupture as well. Okay, so the posterior capsule rupture can also be there, but remember it needs a very small incision of 2.5 to 2.8 mm. It does not need a 5 mm corneal incision. Now remember, such a large incision is used in the ECC. So the answer here is D. Okay, chalo. So the next question is, which of the following is not true regarding the procedure being done here? So what I have done is I have put the patient a trial frame, and with the help of an instrument at 1 meter, I am seeing the fundus reflex and basically seeing the reflex coming from this instrument and comparing it with the fundus reflex of the patient. Okay. So the question is, which of the following is not true? Done for prescribing power of glasses, need dark room. Atropine eye ointment is used in the children for cycloplegia. Tropicamide is the strongest cycloplegic used. So this is a retinoscopy which is going on. Okay, so retinoscopy, we all know, done for prescribing the power of glasses. It needs a dark room. I have basically made the room illuminated to basically take the picture. Atropine eye ointment is used in the patients where there are small children, and we need a very strong cycloplegia here. Remember, it is not the tropicamide which is the strongest cycloplegia. It is the atropine which is the strongest cycloplegia. The tropicamide and phenylephrine, they are the tropicamide is a very mild cycloplegic, and phenylephrine is totally a mydriatic and not a cycloplegic. Okay, so very good, Saurav. So identify the procedure being done here. Your options are pterygium, trabeculectomy, phacoemulsification, or dacryocystorhinostomy. Here you can see what I am doing is making a partial thickness scleral flap, and then it is basically in the partial thickness scleral flap, I have basically made a ostium or one opening in the sclera, and opening in the sclera through which the aqueous humor can basically now drain into the subconjunctival space. Okay, so making a partial thickness scleral flap and making an alternate pathway for the aqueous humor to flow into the subconjunctival space so that you can have a reduced intraocular pressure. What is this surgery which is going on? So very good. This is a trabeculectomy which is going on. Okay, this is a surgery for the glaucoma. I call it glaucoma filtration surgery. Okay, so the glaucoma filtration surgery is the trabeculectomy, जहाँ पर हम एक छोटा सा होल बनाते हैं स्क्लेरा पे around its junction from the limbus, and through this what is happening is that the aqueous humor is flowing into the subconjunctival space. Okay, chalo. Identify the test which is going on. Options are Hess chart, Hirschberg test, prism bar cover test, or Rendot test. Try to answer. Steffi, I would show you the video after this session. Okay, so you have seen that we have put a bar over the front of the eye, and then what we are doing is we are alternating occluding the both eyes. Okay, so we see the movement of the squinting eye, and then we try to neutralize with the prism bar here. Okay, this is a prism bar cover test which is going on. And where I do a prism bar cover test? The prism bar cover test I do for measuring the amount and type of squint. So was not well today, was admitted also. So I think that the energy level from my side is not very high in this session. If you feel that you cannot hear the voice or something is breaking, so you can just let me know in the comment section. I would repeat it again. Okay. Chalo. The next question is, in the following investigation that is going on, which is not true? Can transmit the coronavirus, uses fluorescein dye to stain the cornea, darkroom procedure, does not need anesthesia. If you can see in this picture, what is this going on? This procedure which is going on. Cobalt blue filter is basically being used, and this prism is touching the cornea. Okay, so this is basically a applanation tonometry which is going on. Whenever we do a corneal procedure, what is happening is we are touching the tear film, And latest reports have seen that the mRNA of the COVID virus can also be seen in the tear film and the tear substitutes. Okay, so whenever we touch the applanation tonometer with the tear film, the virus can basically come into the prism and then it can transmit. So after every use of applanation tonometer, we should basically put the tonometer in the 20 minutes in a soap solution, or you can basically clean the tip of the tonometer with the alcohol 90% swab. Now the second thing is, what we do here is we basically put a fluorescein dye to stain the cornea. And whenever I put a fluorescein dye to stain the cornea, what is very important is we should basically anesthetize the cornea with a paracane. Okay, and when we see it in the cobalt blue filter, we can get the Myers like this. Okay, these are the Myers, and they basically should be touching the inner part of the two rings. Okay, this is the absolutely correct intraocular pressure that we can get doing a applanation tonometer. Whenever we do a slit lamp examination, whether I do a gonioscopy, whether I do a applanation tonometry, whether I do a 90D examination, all has to be dark room procedures. Okay, so the answer here is D. So it needs anesthesia. Okay, the anesthesia which I put over the cornea, that is the paracane. Okay, or proparacaine, which we put to topically block the sensations and the reflex that is coming after the touching the cornea. Okay, chalo. The next question is this OCT picture. So your options are not true regarding this condition. I told you when I started the session what is the diagnosis of this patient. So can you tell me the diagnosis of the patient and answer of this question? You can see that the central layers are absent here. So this patient is basically having a macular hole. Seen after trauma, it is absolutely correct. Then first sign is peripheral blurring of vision. Diagnosis is macular hole. Investigation of choice is OCT. So all of them are absolutely correct except the option B. Now whenever we have the macula which is involved, it is not the peripheral blurring, it is the central blurring and the central scotoma that you would see. Okay, Sugandhi? So the central scotomas you would see in these patients of the macular hole or any type of macular disorder. Okay? Chalo. So the next question is, which of the following is not true regarding patient presented with this condition? Okay, so the patient is having this condition. Can you tell me what is this condition? I told you when I started the session, you have a subretinal fluid between the neurosensory retina and RP. So very good, this is a central serous retinopathy. Okay, so my question is, which of the following is not true statement? Seen in young adults, definitely it is seen in young adults in the type A type of personalities. Wait and watch is the treatment modality. This is also correct. It is the wait and watch, and most of the times it resolves simultaneously. It is not wet AMD, it is the central serous retinopathy. Then option C is the flower petal appearance is seen. Remember, the flower petal appearance is seen in the cystoid macular edema. Flower petal appearance is not seen on the central serous retinopathy. You see a appearance like this or a appearance like this. Okay, this is called smokestack appearance, and this is called the ink blot appearance. Okay, so the answer here is C. Is it clear, Rafi? Chalo. Let's move to the next question. This question also I have discussed. Which of the following drugs can cause a retinal condition like this? Your options are beta blockers, alpha agonist, carbonic anhydrase inhibitors, or PG analogs. You can see cystic spaces inside the retina. So this patient is basically having a cystoid macular edema, and as you all know that cystoid macular edema, remember the mnemonic that I have made is the NEET PG. Okay, the NEET PG. So nicotinic acid, epinephrine, tamoxifen and PG analogs. These are the important drugs which can cause the condition like this. So the answer here would be D. Okay, chalo. Let's move to our next question. Not true in a patient presented with this condition. Your options are calcium hydroxyapatite deposition, deposition in Descemet's membrane, EDTA chelation is done for treatment seen in acute uveitis. So tell me, what is the diagnosis of this patient? You can see that there is a band-shaped opacity at the level of cornea, whitish band-shaped opacity. So what is this patient suffering from? This patient is basically suffering from band-shaped keratopathy. And in band-shaped keratopathy, we have the calcium hydroxyapatite deposition. Okay, so deposition is in Descemet's membrane. This is the wrong statement. Deposition is not in the Descemet's membrane. It is in the Bowman's membrane. Okay, and whenever we have the band-shaped keratopathy, to remove the calcium, we can basically do a EDTA, ethylene diamino tetratic acid. EDTA chelation can be done to remove the calcium. It is seen in acute uveitis. This is also wrong. It is not seen in the acute uveitis. It is seen in the patients of chronic uveitis. So both B and D are the correct options here. Why I have put this question? Because in the INI-CET, you can have some questions which have the multiple answers correct. Okay, so that's why what is happening is that whenever you see the question, in at least in your practice sessions, you try to answer as many correct options as possible, unless the examiner says that there is only one option correct. One thing that is for sure in the coming exam is that they would change the pattern again. Last 5 to 6 years, what we have seen is every time we prepare for one pattern, they give you another pattern. Okay, so please have the full concepts with you, full knowledge with you. If you are having a full concept and full knowledge, whatever may be the pattern, you would answer it correctly. Now, band-shaped keratopathy would not change whether it is a image-based question, whether it is a theoretical question, or whether it is a video-based question. It is not going to change whether the one option is correct, whether the two options is correct, whether all the four options are correct. So you have to basically not just practice the questions, you have to practice the topic as well. Okay, so I think that my voice is not very audible right now. Was not feeling well and was admitted also today, so just back. So if you feel that you cannot hear my voice, you can write it in the comment section. I would repeat that again. Okay, chalo. Let's move to the next question. The next question is identify the instrument. So if you can see in the instrument, there are two prongs and they are basically used to hold a suture. So what is this instrument called? So with these two prongs, you can basically hold a suture. This is called a Macpherson's forceps. Okay. So where we use a Macpherson's forceps, we can basically use to hold a intraocular lens, and you can also hold a suture with it. Okay, chalo. Let's move to our next question. So next question is another instrument where you can see that here you are having a wire which is formed a ring. What is this instrument called? Your options are iris repositor, Calazion clamp, enucleation spoon, or wire vectis. So I have taken a session, and the session specifically is on the Unacademy YouTube channel, and the name of the session is Instruments in Ophthalmology. If you want to see all the instruments in ophthalmology, you can just write Instruments in Ophthalmology, type Dr. Vineet Sehgal, and in the YouTube channel of the Unacademy, you would find the link. You can see the video, and if you have any doubt, you can basically put the doubt in the comment section or personally can ask me on the Unacademy Learning app. Okay, so the answer here is D, that is wire vectis. So if you can see here, this is the wire vectis. What I do is that whenever I do a cataract surgery, I have the nucleus. To remove the nucleus, I put the wire vectis beneath the nucleus, okay? And then I put a counter traction here. I put a counter traction here, and this counter traction would help us to basically remove the nucleus to the outside. This is a wire vectis which we use in the patients where I have to do a extra capsular cataract extraction, or if I have to do a small incision cataract surgery. Is it clear? So this is a wire vectis. Okay. So next question is, also you are having the multiple answers correct here. So please study the question. Post cataract surgery, patient presented with pain and redness and a USG picture like this. I showed you the USG picture when I started the session. What is not true regarding this condition? Option A, shows endophthalmitis. Option B, this investigation is also useful in optic neuritis. Option C, oral steroids are the drug of choice in this condition. Option D, intravitreal antibiotics are seen, given. Option E, it is a ocular emergency. So before you answer the question, I would be telling you that more than one option is correct in this question. So you can see the various mild to moderate amplitude spikes after a post cataract surgery. So this patient is definitely suffering from endophthalmitis. Option A is correct. Now for optic neuritis, you do not need a USG for this case. You basically do a direct ophthalmoscopy. If the optic nerve is not visible, in that case you can go for a MRI to see a optic nerve inflammation as well. Okay, so this investigation is not very useful for the optic neuritis because the optic nerve you cannot see very clearly in this picture. Oral steroids are the drug of choice in this condition. This is also wrong. It is not the oral steroids that are needed. It is the intravitreal antibiotics that is the first rule of treatment. If there is an infection in the vitreous cavity, it can basically cause the damage, permanent damage to the retinal cells. So this is a ocular emergency. So the answer here is B and C. If you are liking this session, if you are getting advantage with this session, I would just recommend you and would request you to please give like to the session and please subscribe for our channel as well. Okay, so this is another multiple answers correct. Which of the following is not true regarding this condition? You are seeing the intraocular lens, and behind the intraocular lens you can see some opacities also here. So which of the following is not true regarding this condition? So definitely these are the Elching pearls. So it is definitely more in the patients who are having a posterior chamber intraocular lens implant. Okay, so pseudophakia with posterior capsular opacification, in these patients you get a Elching pearls. Now they are more common in acrylic lenses than in PMMA. Now this is a wrong statement. The acrylic lenses have the least incidence of the posterior capsular opacification, and the PMMA lenses are having the maximum incidence of the Elching pearls or posterior capsular opacification. Now option C, double frequency Nd:YAG is used. Is it true or false? So also called Elching spots, this is correct. Can cause central blurring of vision, this is also correct. My question to all of you, my friends, is double frequency Nd:YAG is used. Is this a correct statement? So it is not a correct statement. We do not use double frequency Nd:YAG here. We use a single frequency Nd:YAG here. Okay, we use a single frequency Nd:YAG. A double frequency Nd:YAG we use in the patients where we have to do a pan-retinal photocoagulation. Okay. Chalo. This is our next question. Not a true statement regarding this condition. Used to detect red-green color blindness. Color blindness is more common in males. Important criteria for driving license. Patient with cataract has impaired response to the Ischera chart. So this is a Ischera chart which is basically seen. My question here is, which of the following is not a true statement? Let's see all the options one by one. Used to detect red-green color blindness. Now this is absolutely a correct statement. Ischera charts. The first line of the test for measuring the color blindness is basically measuring the red-green color blindness. More commonly, the red-green color blindness is seen after the drug-induced optic neuritis, like we get it in ethambutol-induced color blindness. Okay, so in these cases and also in a general population, you can use the Ishira chart where you have a lot of plates. The patient has to basically see all through the plates and see various patterns and various figures there. Okay, in this way you can basically tell how much is the color vision deficiency in these patients. Now this color blindness is more common in males because it is there in the X chromosome. Okay, because the males are having XY and the females are having XS. So the females are usually the carriers and the males are the ones where it basically have more impact. Important criteria for driving license, very true. The reason is because you have red, green and yellow light. So if you are not able to see the red and green colors, then there would be a problem in whenever you drive. So it is definitely an important criteria for driving license. Now this type of color vision deficiency, this is seen more on the optic nerve head disorders and it is not seen in the cataract or in the corneal opacities. Okay, so patient with cataract has impaired response to the Ishira chart. This is a wrong statement. The patient with cataract has normal response to the Ishira chart. So the answer here would be D. Is it clear? Chalo. Let's move to our next question. Mark the true statements regarding this procedure. First of all, tell me what is this procedure which is going on. If you are enjoying this session, please give a thumbs up to the session and like our video. So very good. This is a direct ophthalmoscopy which is going on. So remember, whenever you see a direct ophthalmoscopy, you remember a very famous hero in the Hindi films, that is Devanand. So direct ophthalmoscopy, you have the erect and the virtual image. Okay, it is basically used to see the posterior pole. What are the two components that are there in the posterior pole? It is the optic nerve head plus the macula. So any pathology in the optic nerve head and macula, you can see through this direct ophthalmoscope. Can be used to see through the hazy media. This is a wrong statement. Remember, a direct ophthalmoscope, basically it has the low illumination, so it cannot see through the hazy media, and can be used to still see till the peripheral retina. This is also wrong. Okay, so it can see only the optic nerve head and macula. For these two patients, we need a indirect ophthalmoscopy. So here also the two options are correct and these are option C and option D. Is it clear, Prabhu? Chalo, let's move to our next question. So the next question is, a patient presented with this type of clinical picture. Just give me a minute. Let me make this slide more clear to you. Now I think it is more clear. Can you read these slides now? Okay. So the patient presented with this type of clinical picture, patient does not have any history of any inflammation. The visual acuity is 6/9, so this means there is a good visual acuity. What is your probable diagnosis? In this patient, what you can see is around the cornea you have the corneal opacity, and around the corneal opacity you can see there is in the center. A very important phenomena which is given here is that the patient does not have any history of any inflammation. So option B and option D can basically be ruled out. Now your options are Cogan Maprint dot dystrophy or granular dystrophy. Now remember, Cogan Maprint dot dystrophy is a epithelial dystrophy. So whenever there is a epithelial defect, there would be a redness, watering in the patient. In this patient, you are not having any signs of the redness and watering. So this is not a Cogan Maprint dystrophy. This is a granular dystrophy, which is a type of stromal dystrophy. Very important point whenever you are having a granular dystrophy is that you have the opacities in the center, and as you can see in this picture that the area which is between the two opacities, that is normal. Okay, दिस इज द मोस्ट इम्पॉर्टेंट एंड स्पेसिफिक फीचर ऑफ अ ग्रेनुलर डिस्ट्रॉफी कि जो ओपेसिटीज के बीच का एरिया होता है वो नॉर्मल होता है एंड स्टेज तक. सो पेशेंट की विजन जो है वो बहुत ज़्यादा खराब नहीं होती. पेशेंट्स विजन इज almost normal or just below the normal. So you are seeing that this is a 6/9 image. If the patient is having a macular dystrophy, then the area between the two dystrophies, the area between the two opacities, that is also hazy. So in that cases, what is happening is that the total amount or the total area or the total vision is very much decreased. So you get a vision by 1/60 or 2/60 in these patients. So in that cases, it is very important to do a corneal transplant as soon as possible. Okay, chalo, let's move to our next question. Not true regarding this ocular condition. First of all, tell me what is this ocular condition shown here? So very good. This is a ectopia lentis and there is a superior-temporal subluxation here. Lens is going superior-temporal. Okay. So superior-temporal subluxation is usually associated with the Marfan syndrome. Okay. And if you can see a reflex this is the aphakic part. So you get different retinoscopy values from the aphakic area and from the phakic area. So this reflex is called crescent reflex. Because in the Marfan syndrome, you may be having the cardiovascular anomalies as well. So the patient may need a systemic evaluation also. In these patients, you have already the weakened zonules. So you cannot do a ECC in these patients. Either you have to remove whole of the lens with the capsule, that is called ICCE, the intracapsular cataract extraction. Or what you can do is you can just put a ring inside the anterior capsule, that is called a Sionese ring. So you can have a Sionese ring, and basically what the Sionese ring does is Sionese ring basically stabilize the capsule and then you can put a intraocular lens as well. But definitely ECC should not be done in these cases. Okay. So our next question is a 65-year-old patient came to the OPD with following OCT picture and complains of metamorphosia. What is the most probable diagnosis here? That is your macular hole, ARMD, central serous retinopathy or cystoid macular edema. Try to answer fast. In this patient, what you can appreciate is that there is a elevation of the RPE. The rest of the layers seem to be normal. So it is not definitely a macular hole. Okay, there is no fluid collection, so it is not a central serous retinopathy. It is not a cystoid macular edema because there is an elevation of the RPE. This is the patient suffering from ARMD. Also, you can see the age is also collaborating here. Okay, so this patient is having a ARMD, the age-related macular degeneration. Okay, then we have the next question for you. The investigation is used for all of the following except your options are keratoconus, preoperative LASIK checkup, keratoglobus or herpes keratitis. So this investigation which you can see here, this is a pentacam which is going on. In the pentacam, what you can see is the anterior corneal curvature as well as the posterior corneal curvature. But what you cannot appreciate in these patients is that you cannot see the how much is the inflammation of the cornea there, and you cannot see about the dendritic ulcers there, which are the phenomena that are seen in the herpes keratitis. So herpes keratitis is more of a clinical diagnosis which you do in the slit lamp and not with the help of the pentacam. Pentacam is used for any corneal topographic disorders like keratoconus and keratoglobus, and also for the preoperative LASIK checkup. Now, how would you differentiate between a keratoconus and keratoglobus? In the keratoconus, the thinnest part of the cornea would be centrally or paracentrally. Are you getting my point? So, जो सबसे thin part है cornea का वो centrally या paracentrally होगा. In keratoglobus, what is happening is that this patient is having a total round cornea where the thinning is throughout all of the cornea. Okay, so सारी cornea जो है वो thinned है. This is a keratoglobus. It is the same thinning all around the cornea in the keratoglobus. In the keratoconus, it is the central or the paracentral part which is the thinnest. Okay, chalo, let's move to our next question. A patient presented to the IOPD with a patient with this clinical picture, and patient is having a foreign body sensation also. On examination, there is no foreign body, and you can see from the posterior part of the eyelids there is a milky or sebum type yellowish secretion. What is this patient suffering from? So this patient is basically suffering from a meibomian gland dysfunction. Okay, this is a meibomian gland dysfunction. I also call it posterior blepharitis. Why I call it a posterior blepharitis? If you can see around these holes, there is yellowish sebum-like material which is expressing. So because the meibomian inflammation is there, the accumulation is there, there is bacterial multiplication there. So these glands are inflamed and the patient feels a foreign body sensation. The patient also may be having a ocular surface disease in these patients. Okay, chalo. The next question is, a patient presented with the following clinical picture and glaucoma. What is the cause of glaucoma in this child? First of all, tell me what is the diagnosis of this patient. You can see a port wine stain here. A port wine stain here in one part of the face. So this is a patient who is suffering from Sturge-Weber syndrome. Whenever the patient is suffering from Sturge-Weber syndrome, there can be glaucoma in these patients because of the increased episcleral venous pressure. Okay, so remember what is happening is that after trabecular meshwork, the Schlemm's canal is basically draining the aqueous humor, okay, and through the episcleral space. When there is a pressure in this episcleral area, okay, so this basically gets constricted and the drainage is not possible there. This can happen in Sturge-Weber syndrome. It can also happen in the thyroid ophthalmopathy or in the cavernous hemangiomas. Chalo, let's move to our next question. The most common cause of unilateral proptosis in adults is, your options are UVL melanoma, retinoblastoma, thyroid ophthalmopathy or neuroblastoma. If you can see, there is a frightening look of this patient and there is a upper lid retraction also. So this patient is having a sign which is called a Dalrympe sign. And whenever you see a Dalrympe sign, the patient is basically suffering from thyroid ophthalmopathy. So remember, the thyroid ophthalmopathy is the most common cause of proptosis, both unilaterally as well as bilaterally. Okay, it is the most common cause of the proptosis in adults. If they ask in children, if they ask the unilateral in children, then the answer is different. The answer then becomes orbital cellulitis. If they ask bilateral, then the answer is neuroblastoma. If the neuroblastoma is not given in the option, the second option which you can opt for is the chloroma. Okay, so you can just see the most common in ophthalmology list, which I have taken a many sessions. It is available in our notes as well, and I have uploaded in the Unacademy learning app the study material of ophthalmology, where you can basically see the most common list in ophthalmology. Okay, chalo. Then you tell me what is the type of intraocular lens implanted in this condition. You can see variety of rings in this patient. So these rings can basically help the patient to focus at different points. Okay, so this is called a multifocal posterior chamber intraocular lens. Okay, identify this procedure which is going on. You can see we have basically made a rhexis with the help of a laser. We are mapping the nucleus and the thickness of the lens, and we are making a corneal incision as well. So what is this procedure which is going on? So very good. This is a femto laser assisted cataract surgery which is going on. Another question they asked regarding the femto laser is its wavelength. Can anyone tell me what is the wavelength of the femto laser and what is the frequency? So frequency is 10 raised to power minus 15. Wavelength is 1053 nanometer. Okay, chalo, let's move to our next question. Which is the type of staphyloma seen in this picture? You are seeing that after a sloughing corneal ulcer, you are having a pseudo membrane over the uveal tissue and there is a protrusion of the uveal tissue from the anterior part. So this is basically as simple as that. It is the anterior staphyloma. Remember, staphyloma is basically the protrusion of the uveal tissue through the thinned out coats. So if it is occurring from the cornea, it is called anterior. If it is at the level of optic nerve head and macula, it is called posterior. If it is at the region of ciliary body, it is called ciliary staphyloma. If it is level at the vortex veins, where the vortex veins leave the eye, then it is called a equatorial staphyloma. Okay. Chalo. Then this is my next question. Identify the procedure being done in the patient. Is it a soft contact lens, a hard contact lens, intracorneal ring segments, or whether it is a corneal transplant which is going on? So in this picture you can very easily see that there is a ring which I have put inside the stroma. This is the stroma and here I have put a ring. So what it does is it can basically stiffen the cornea and would change the curvature of cornea as well. So we get two advantages here. Refractive error is corrected, and second thing what we can basically see in this patient, the cornea is stabilized. So this is basically a intact intracorneal ring segments. The intracorneal ring segments we use in the patients of the keratoconus. Okay, so the answer is keratoconus here. Chalo. Now I would be showing you, before I end the session, few videos. Just identify what is the procedure going on. Okay, can you tell me what is the procedure going on? So I have put a scan, instrument over the eyeball. Okay, I have put the instrument over the eyeball, and then after putting the instrument over the eyeball, I am putting some fluid here. Okay, so this is called immersion biometry, and immersion biometry, can you see here? This is the A scan. This is not the B scan. This is the A scan. What you can see is the amplitude spikes here. Can you see yo-yo here? This is the A scan which is going on, and A scan basically when we do it, whenever we have to see the IOL power. So the procedure which I am doing here is the biometry. Do you like this video? Okay. So let us show you another video. So whenever you have a B scan, you would have I would show you a B scan video as well. First, see this video. What is the procedure going on? So very good, Nirupama. This is basically the gonioscopy going on. Okay, this is the gonioscope. This is the 4-mirror gonioscope which I am using to see the anterior chamber angles of the patient. Okay, this is a gonioscope. Now, one question which was asked from one of the student is how to basically differentiate a USG B scan with the USG A scan. I would just show you the video as well. So can you see this picture? So this is the same, almost same type of probe I am putting over the eye, and what you are seeing is the, can you see here? So see what are the spikes that we are getting, what is the image we are getting. This is called a B scan. Okay, brightness scan. Now remember, with same probe you can do a USGB scan as well as USG A scan also. Okay, but the figure or the picture that you get in a B scan and A scan, that would be different. This would be a picture of the B scan, and what I showed you earlier, that is the picture of the A scan. Is it clear, Yo-Yo? Okay, let's move to the next video. Okay, so here I am checking the action of one of the muscle. Okay, no, sorry, this is a phenomena which I am basically checking. What is this phenomena called? So eye is going up and out. So Prabhu, that is distilled water. So that we want some of the fluid interface, so that the light rays should not, the ultrasound rays should not go outside. Okay, so that's why we put a gel over the eyelid, or we put water inside the over the cornea, so that the USG rays do not dissipate around. So can you see this phenomena, everyone? What is this phenomena called? Where you are basically seeing the eye going up and out. So very good. This is the Bell's phenomena which you are seeing here. Okay. Now this is a surgery which is a phacoemulsification. Can you see? So what I am doing is I am just going inside the eye with a phacoemulsification probe. Okay. And I am taking out whole of the cortical material, and with the help of the chopper I am separating the various nuclear particles there. So this is a phacoemulsification going on, phacoemulsification surgery. Can you see here? Okay, do not confuse it with the trab surgery. I would be just showing you a trab surgery as well. So this is a trap going on, if you can see here. So I have basically made a partial thickness scleral flap. Okay, doing a paracentesis, removing a part of sclera that is called ostium, and then I reposit it, and it is basically making an alternative channel for the aqueous humor to flow outside. This is called a trabeculectomy surgery. Are you getting my point, everyone? So this is a trabeculectomy surgery which is going on. So are you enjoying the session? Chalo, let's move to our next video. Okay, so this is over. So with this, I end my session, and before I end my session, I thank you, all of you, for attending this session at late night, and we would be having a lot of sessions like this. Before I end the session, I would request all of you who are here, it is a request to all of you, just give a thumbs up to the session. You can just click on the like button, and also share and subscribe our YouTube channel. I am there on the also the Unacademy Telegram group. You can just join it. The link of the Unacademy Telegram group is basically given in the description of this session. If you have any doubts, you can ask me there also. Before I end the session, I would be just telling you that there are few features of the Unacademy NEET PG preparation. Yes, I take classes every day. So there are few features which I would be telling you. That is the NEET PG season 1 batch, FMG test and analysis batch, lot of MCQs there, and also you should be remembering that for 3 months subscription you would get a 1 month subscription free of cost to all of you. Okay, in the plus subscription you would have the advantage of the daily live classes, live test and quizzes, structured course, and unlimited access. With this I end my session. Hope you would have liked the session. Tomorrow I would come with another session on the rapid revision series in ophthalmology at 10:30 p.m. and the topic would be uveitis there. Okay, so the topic of the class at 10:30 p.m. would be uveitis. You would basically have a lot of questions on uveitis there. There are lots of controversies there, and within 15 to 20 minutes it would be a short session. Definitely we would basically try to cover all of them. Till then, it is good night from my side. Jai Hind and take care.